So first of all, I really would like to thank all of you for being here, Nutricia for organizing these meeting. And during the next 45 minutes or so, I would like to give you some information about the importance of Kakeksi. What is Kakeksi in cancer patient? Why we should take care of that. So basically, this is my email address for any question, any doubts, but you already have the handouts with all my presentation. So first of all, I really would like to tell you some information about cancer in general. And okay, so first of all, we already know that there will be more and more cancer patients in the next future. Why? Because the population is growing older and older. Just to give you an example, this is a nice study coming from UK. You see here that those, maybe you can stay here so you can have a better view. So actually, you see here that those who were born in the 1930s, they had approximately a 35% chance of developing any kind of cancer during lifetime. But you see that those who are born in the 1960s, they have a 50% chances of developing any kind of cancer during their lifetime. So make your calculations. I already had mine when I was 8 months. I had a benign cancer. So, but this really highlights the importance of being aware that cancer will become one of the major problems in the next future. There is also another major problem, which is shown in these studies, that the population in the world is getting fatter and diabetes is becoming more prevalent. And you see that in 2012, approximately 3,000 cancer cases all over the world could be attributed only, for example, to high BMI or maybe to diabetes. So it really means that the more the population is growing older, the more population is growing fat and fat, we will have more and more cancer patients. But there is another major problem. The management of these patients is very, very expensive. So this is a rough calculation of the management in 2007 of cancer patients. You see that the cost was approximately $290 billion per year. But what happens in 2030 if the current rate of increase are the same, will be the same, we will spend all over the world approximately $460 billion each year. And most of these is because of the costs of the drugs, which are very expensive, and I will show you some data which you probably already know, but are quite frightening about the cost and the effectiveness of these treatments. The drugs we are now using are they're supposedly to be very, very effective because we now know a lot about cancer patients. We know a lot of molecular things about cancers. So the idea that we now have is that we know very well the molecular damage of a cancer cell. So we can use a specific drug which targets that specific molecular change. And of course, we will have better apoptosis, better necrosis, better survival for the patients. But this is in the lab. What happens in the real world? Well, unfortunately, personalized medicine is still a dream in oncology. This is one of the very few studies which are trying to compare what happens in terms of progression-free survival when oncologists prepare a treatment which is based on the molecular changes of the tumor cells or the standard way of delivering therapy. And you see that there is absolutely no difference in terms of survival. Meaning that even if we know exactly which is the molecular problem in each single cancer cells, not necessarily by targeting that change, we can have an improved survival for the patients. So there's something more. And what is this something more? Well, we know very well that cancer cells have specific characteristics. More importantly, they invade blood vessels, they invade the tissues, and so on. But more importantly, they may triggered the onset of the so-called paraneoplastic syndrome. And indeed, cancer cachexia is one of the most widely represented paraneoplastic syndrome. I will just touch upon these. What is cachexia? Is comprised under the umbrella of malnutrition syndromes, but you see here it is because of the changes in appetite, reduction of food intake, but also inflammation driven by the tumor, and more importantly, given to changes in the metabolism. But how frequent, how prevalent is cancer-associated cachexia? Quite a lot. You see here that there are, in some cancers, like the pancreatic cancer, approximately 60 to 70% of the patients are affected by cachexia. So almost all cancer patients with the pancreatic disease, they have cancer cachexia. And again, you see also that the degree of weight loss can be extremely high. These patients here with pancreatic cancer, they have up to 15, 20, 25% loss of body weight because of the presence of the tumor. More importantly, the problem of malnutrition and weight loss is not only of the patient with pancreatic cancer. These are data from Italy, approximately 1,000 cancer patients upon their first visit to an oncology clinic. You see here that many patients have already a stage 4 disease, even if they have the first time that they meet an oncologist. Particularly, you see here that 80% with liver cancer, when they first meet an oncologist, they already have an advanced cancer. What is frightening is here, you see here that independently of the stage of the tumor, when the patients meet the first time oncologist, the incidence of malnutrition, risk of malnutrition is very high. If you include all the stages of disease, you will see that approximately 50% are either malnourished or at risk of malnutrition. So this is very, very high. Now the question is, okay, but who cares about malnutrition? Is malnutrition something which is related to aesthetic medicine? So we should take care of malnutrition because it's not very nice to see these skinny patients in our outpatient clinic. Oh, malnutrition is a clinically relevant problem. I will show you only a few data because now on this planet, and I would say in the galaxy, there is nobody who can deny that malnutrition is a significant negative outcome, prognostic factor for cancer patients. This is just Chinese data, approximately 400 cancer patients, and you see that even a minimal weight loss, approximately 3%, is associated with the shortening of the survival of these patients. And more important, this is even if the weight loss develops before or during chemo, which really means that the malnutrition is something which may develop because of the treatment, not only because of the presence of the tumor. So we really need to monitor cancer patients during the treatment. To highlight the importance of weight loss, so this is again another study showing that indeed, if a cancer patient gains body weight during treatment, he has a better prognosis, a better survival. You see here that the patient with a weight gain more than 5% get a better survival when compared to patients who are actually not gaining weight. I just want to highlight one aspect of this slide. You see here that the benefit is really here at the beginning, which really means that if we wait in helping patients to gain weight, probably we will not get the same effects. But the question now is, okay, is cachexia body weight loss? Of course not. Actually, cachexia is better defined by a change in body composition and, more importantly, changes in muscle mass. And indeed, the most widely recognized definition of cancer cachexia, really highlights that the key feature you see here is really muscle loss, with or without changes also in adipose tissue. And you see that this is because of the variable combination in each patient of a reduction of food intake plus changes in the metabolism, and protein metabolism, lipid metabolism, carbohydrate metabolism of these patients. So in this paper, they were also suggesting some tools to make a diagnosis of cancer cachexia. You can use the weight loss greater than 5% of the past 6 months, or a BMI lower than 20 and any degree of weight loss greater than 2%, or you can actually measure muscle mass in these patients, and we will learn more later on how to do that. The importance of muscle mass in determining and influencing the outcome of cancer patients is shown by these slide. These are cancer patients, but these are obese cancer patients. So you would think that losing body weight in a cancer patient should not result in big problem, because these are big men, big women, so they should not have any major problem in reducing body weight. But you see here that if a patient actually is sarcopenic, even if he's obese, has a shorter survival when compared to cancer patients with obesity and without sarcopenia. So really, it really appears that muscle mass is the key feature of this paraneoplastic syndrome, which is cachexia. Now the question is, why a cancer patient with low muscle mass should die faster? Which are the rationale? Well, one potential explanation is the fact that the reduction of muscle mass is associated with increased incidence of dose-limiting toxicities. This is a study coming from France. These are patients with liver hepatocellular carcinoma receiving sorafenib, and you see that the patients who are sarcopenic, they have an increased incidence of dose-limiting toxicities. I just want to remind you, because of course you always or you already know that dose-limiting toxicity means a toxicity because of the treatment which forces the oncologist to reduce or to delay the dose of the treatment, which means that these patients here, they are receiving less of what was originally planned. And so they are not getting all the benefits of the anti-cancer treatment. And probably this is one of the reasons why a cancer patient with sarcopenia has a shorter survival, because he's not receiving the exact dose what was planned for him. And there is also an explanation why these patients may have an increased incidence of toxicity, which could be related, for example, to the distribution of the drug, of the chemotherapeutic drugs in cancer patients because of the changes in the body composition. So probably many patients are either overtreated or undertreated because the distribution volume is changed, is altered in patients with cachexia. These are more recent study, and again, now there is absolutely no doubt that the presence of low muscle mass is associated with early discontinuation, treatment delay, and dose reduction, whatever regimen you are thinking of, oxaliplatin, fluorouracil. All these treatments are associated with increased toxicity in patients with sarcopenia. Now, sarcopenia is not only a syndrome which is relevant in medical cancer patients, but also in surgical cancer patients. This is an almost old study coming from UK, and again, you see that the patients who are put on the operating table with sarcopenia, they have an increased incidence of postoperative complications. So surgeons, oncology surgeons already know that if they are operating on a cancer patient with sarcopenia, they will have more and more complications in the postoperative period. This is just to remind you the importance of really measuring muscle mass, because, and we will see maybe later, you see that these two patients actually have the same BMI, but you see that the
the amount of muscle mass in these two patients is quite different. And of course, we should not really be, fooled by our eyes, and try always to measure the muscle mass. What about adipose tissue? So far we focus particularly on muscle mass, but has adipose tissue any role in influencing the outcome of a cancer patient? These are data coming from Canada, and again they were looking at the adipose tissue of cancer patients. And once more, a low subcutaneous adiposity is associated with a shorter survival for cancer patients. And of course, if you combine the adipose tissue and the muscle mass, you will see that the worst combination a cancer patient may have is this one: low visceral adipose tissue, low subcutaneous adipose tissue, sarcopenia, and this is associated with a median survival of only 10 months. So this is the worst combination, nutritional combination, that a cancer patient may have. I fully understand that it may not be easy to precisely measure muscle mass in all cancer patients in daily practice. Asking a CT scan for a cancer patient just because you want to know body composition could be difficult to be approved. So the Canadian group actually suggested to use other two factors which appears to influence the outcome of cancer patients. So you have to use the BMI of your patient and the degree of weight loss. So let's say that you have a patient who has a BMI of 27 and has lost approximately 10% of his body weight. So this patient, 27 and 10%, should be here in this section which is called 3. And you see this patient will have a median survival of only 7.6 months. This is an easy strategy to at least identify the patients with a shorter prognosis, with a worse prognosis, without having the necessity of assessing body composition in these patients. I have to say that recently I read this paper with a statistician, a real statistician, not a biostatistician, a real statistician, and she was horrified because she was saying that this very nice paper published in a fantastic study, originally was Journal of Oncology, was actually based on unadjusted values. So she was quite horrified. But I can tell you that now, for example, when you have to start a clinical trial and you want to include patients who have a quite decent survival time, we use this kind of tool to assess which patient should be enrolled in a clinical trial. Having said that, another important message is the fact that, of course, cachexia does not develop in one day. It's extremely unlikely that today you meet a cancer patient at your outpatient clinic and next week the patient is already severely cachectic. Quite unlikely. It may happen, but it's quite unlikely. So actually, one of the most important things that the collaborative group has developed is this kind of staging of cachexia, which goes from pre-cachexia, which is those patients with minimal, if any, weight loss, but with nutrition risk symptoms, like, for example, changes in appetite, changes in taste. That's a patient which can be defined as pre-cachectic because it's a patient at higher risk of developing cachexia. When weight loss develops, then you have the cachexia syndrome. And then if nothing is done for these patients, then the refractory cachexia develops, which is very difficult to assess when it is, meaning that it is when the patient has lost 10%, when the patient lost 15%, 20%. We don't know very well the main reason why the concept of refractory cachexia has been developed is to highlight the importance not to wait this stage to start your treatment, because this patient will not responsive to any kind of treatment you can think of. But just a few words about the fact that so far there is good acknowledgement, good agreement on the fact that malnutrition and cachexia is a nutritional syndrome with, of course, implications in terms of the clinical outcome of the patients. But is cachexia only a nutritional syndrome? Or we are just focusing on muscle because we are not looking at other factors, other domains which may be as relevant as muscle mass? Indeed, skeletal muscle mass is one of the most important targets of cachexia. But we should not forget that cachexia has negative effects on the brain, on the adipose tissue, on the heart, on the liver, even on the gut. So if we think at the cachexia domains, we all agree that these are the cachexia domains which are very well established. The muscle mass, inflammation, changes in appetite and changes in the food intake, the importance of age, of course, because usually cancer patients are older adults. So you have also to combine the negative effects of the presence of the tumor with the effects of muscle mass of aging, the changes in adiposity. But there are other important domains which are affected by the presence of cachexia, like the immune system, like the changes in psychological status of these patients. Microbiota. There are a lot of new emerging evidence showing that cancer patients and cancer patients with cachexia have a specific microbiota. Is this the consequence of the cancer, or is just the cause of the cancer or the cachexia? We don't know yet. The physical activity, how much of the cachexia is because these patients are not moving, maybe are bedridden or sit on the chair for a long period of time? How much of the cachexia is because these patients are polymorbid? They're receiving many drugs. And for example, how much of the cachexia is because there is a specific change in the metabolism of these patients? I'm very much interested in the changes in the immune system of cancer patients. And I'm trying really to identify whether a specific link may exist between muscle mass and immune response. Just to give you some idea, these are the data from the Nutrition Day Oncology. You know that Nutrition Day is a large ESPEN project which every year actually looks at the nutritional care and nutritional status of patients hospitalized. Since 2012, we are also launching a Nutrition Day Oncology, which is specific for cancer patients. And so far, we have enrolled in the database approximately 9,000 cancer patients. So if you look at the old data set, you will see that the 30-day mortality is approximately 7%, which is quite good because you know that one of the quality requirement is that patients receiving chemotherapy should not die during the next 30 days, and this rate of death should not be more than 10%. But if you look only to the patients with systemic infections, you see that the mortality rate is doubled to 14.9%. And if you look at the more specific group, like the patients with systemic infections and weight loss, you still have 15%, which means that most of the death because of systemic infections in cancer patients are associated with weight loss, which may suggest that there could be some kind of link between weight loss, muscle mass, and immunity. And there are also very interesting data, experimental data that now we are trying to validate in humans, showing that indeed muscle mass is associated, could be also a marker of the immune status, and more importantly, of the intratumoral immunity. This is a very nice study. The animals were, of course, harboring a tumor. The tumor is producing IL-6, and IL-6 has a negative impact on liver metabolism. Particularly, it has a reduction of PPAR-alpha, which is the main driver of ketogenesis. So it may happen that in cancer patients with increased inflammatory response, there is a reduction in the circulating ketone bodies. You may say, who cares about ketone bodies? No, we do care about ketone body, because you know very well that when there is a significant reduction of energy, of food intake, we survive because of ketone bodies. So what happens until the animal is eating enough, the fact that there is not enough ketone bodies doesn't really make a big change. But in case of caloric deficiency, there is a metabolic stress response, which is associated with increase of glucocorticoids, with increased muscle mass destruction, but more importantly, a reduction in the intratumoral immunity and reduction in the efficacy of immune therapy. So it's really possible that muscle mass could be linked to very specific immune response in cancer patients. And this is extremely important because you know much better than me that we're now living in very interesting times. And there is more and more interest about the role of immunotherapy. Immune therapy is a different concept. You know better than me, and I just want to remind to myself that the concept here is much different. You really don't want to kill all the cancer cells because through the chemotherapy and radiotherapy. You just want to control the cancer cells. You just want to become that cancer becomes a chronic disease like diabetes, like hypertension. You don't want really to kill all the cancer cells. And this you see here is associated with a better outcome of cancer patients with advanced disease. Unfortunately, even in immune therapy, we are not really interested in looking at the changes in the immune system. You see here that even in the immunotherapy trials, the assessment of efficacy is mainly based on imaging, which of course is important, but you really need to see what happens in the terms of the immune cells. And indeed, there are now very interesting studies showing that this kind of prognostic, immune prognostic index is a good predictor of survival for cancer patients. So far we knew that with chemotherapy and radiotherapy, nutrition was important. Muscle mass was important. But what with this new emerging way of treating cancer patients? Is now nutrition with immune therapy still relevant? Of course, yes. This is a rhetorical question. You see here, this is a Japanese study, and you see that the prognostic nutritional index is one of the very few prognostic marker for patients receiving immune therapy, together with the neutrophil to lymphocyte ratio. So it really seems that Kakeksi, although it is its feature is muscle mass, one of the major problems that causes is probably changes in the immune system. So, but what about then how to use this information to enhance and improve the treatment of cancer patients? First of all, do we really need to enhance the efficacy of anti-cancer treatment? Is there any need to improve the outcome? Well, unfortunately, yes. These are the US statistics, the most recent statistic published last year. You see here that during the last 40 years, there has been a significant increase in the incidence of tumors, but a reduction in mortality. And of course, you would say that's fantastic. We have more cancer patients, but we have less patients dying from cancer. So we are really good in treating cancer patients. But look at here. These are the data when are stratified according to the stage of the disease when the patient is diagnosed. So let's look at what happened 6 years ago. Cancer statistic 2012, lung cancer. Patients who were diagnosed with distant metastases had 4% chances to be alive after 5 years. In 2017, after 5 years, the rate of survival after 5 years is approximately the same. So during 5 years, we really didn't improve significantly the outcome of cancer patients with advanced disease, which could be interpreted that the fact that indeed it's true that we have less patients dying for cancer, but at least part of this improvement is because we are diagnosing cancer patients at an earlier stage. So we can send the patient to the surgeon removes the tumor, the patient is cured. We still have problems in treating effectively patients with advanced disease. Not only that, the drugs that we are using are extremely expensive. But you would say, okay, I don't care. I can spend even 100,000 euros or dollars or crowns to treat effectively a patient. But it seems that actually in the real world, the drugs which are more expensive are actually those who are less effective. And these are data published in Lancet Oncology based on validated tools to identify the efficacy of anti-cancer treatment. Not only that, if you consider the drugs which are used and which have been validated based on thousands of patients' trials, you will see that only 50% of them are still effective in daily practice, which highlights another important fact that we already know, that there is a great difference between the protected environment of a clinical trial and the real life. So what we can do to help and to improve these data? Is nutrition a potential strategy by which we can improve the outcome of these patients? Well, let's consider how to treat cachexia or to prevent cachexia in these patients. We already know that cancer cachexia is because of these changes, for example, in energy intake and changes in metabolism. So the patients are spending more energy and eating less energy. Therefore, the idea is to fill the gap. What happens if we fill this gap? If we have the patients meeting energy and protein requirements, even if the patients are anorexic, they don't want to eat. First of all, we have to remember another important aspect, the fact that the treatment of a cancer patient should really last for months or even for years. And if you think that this is the classical clinical journey of a cancer patient, we have to remember that during this long journey, the patient faces periods of crisis. It could be the psychological discomfort of diagnosis, the negative effects of chemotherapy, the negative effects of surgery or adjuvant or palliative care. You see that there is a drop of the nutritional status and nutritional function in these patients. And unfortunately, there is no possibility for the patient to recover and get back to the baseline value. So at the end, if we focus only here, but we forget this period of the clinical journey of the patient, probably we will not get a significant clinical benefit. So any treatment that you can think a cancer patient, particularly a patient with advanced cancer, may get, each of these is associated with a reduction in nutritional status. And so the idea is that while now we have patients with cancer, we apply chemotherapy, which have a negative effects, of course, on the cancer cell, but also on the cancer patients, sometimes worsening cachexia. The idea is to provide the patient with some kind of a shield, which may help the treatment to be more effective on the cancer cells without having the negative effects on cancer patients. Therefore, the idea is not really to have a patient receiving aggressive chemo, radiotherapy with no weight loss. The idea of nutritional support in cancer patients is to minimize weight loss during the crisis and maximize, of course, the recovery phase. That should be our goal. And what we can do for these patients? Well, unfortunately not for this patient who is really suffering from refractory cachexia. Well, of course, the idea is to use a nutritional approach. And you see that if you go into clinicaltrials.gov, you see that the majority of the trials are really involving a nutritional approach. What we have to do, again, I told you, is to try to help the patient to meet energy and protein requirements. And quite recently, the European Society for Clinical Nutrition and Metabolism, ESPEN, has issued these guidelines. And the patient should eat a range between 25 and 30 kilocalories per kilo body weight per day, and should eat 1 gram of protein per day, 1 gram per kilo per day, and up to 1.5 grams per kilo per day. These are the goals of a cancer patient. We should try, of course, to have the patient, particularly in the recovery phase, to meet these goals. But of course, there is another problem. Kakeksi, I told you before, and Tommy will tell us, is not only reduction of food intake. It's also changes in the metabolism because of the inflammatory response induced by the tumor, which is really part of the changes that we see in the brain, in the muscle, in the different organs in a cancer patient. So we really need to not only fill the gap, but also modulate the inflammatory response by using, for example, nutrients which have been demonstrated to have anti-inflammatory response, like omega-3 fatty acids. This is just to show you the complexity of these of the changes in the muscle metabolism because of inflammation. And you see here that, again, the ESPEN guidelines suggest to use supplementation of omega-3 fatty acids at a dose of EPA and DHA, which should approximately 1.5 grams per day to 2.0 grams per day, in patients with cancer in order to minimize, for example, weight loss. Now the question is, okay, very interesting, but do we have any data helping us to convince someone that this is really what we have to do, and more importantly, that we can improve the outcome of patients? This is a study coming from Belgium. These are patients in whom the authors were really trying to meet energy and protein requirements every day during the treatment period. It's a pilot study, so I have to say that the number of patients is limited. So we really don't know if this is these effects, particularly these one, are really effective, or is just biased by the small number. But you see that the patients who are actually receiving nutrition therapy during treatment has less days of unexpected hospital stay, which can be a surrogate marker of less toxicity, less severe toxicity. And also it appears that these patients actually had a better survival, although, again, I have to warn all of us that this study was not powered to measure survival. So it's fantastic, but we need more studies to validate this information. More interesting is this study. This is the results of the Scope 1 study. The Scope 1 study was a nice study which was testing whether the combination of two drugs was better than providing only one drug in the treatment of esophageal cancer at an advanced stage. The study was stopped for futility because there was no improvement in survival for patients receiving two drugs compared to patients receiving only one drug. But the interesting thing in this study is the fact that the authors were also collecting data on the nutritional status of the patients. So they saw that indeed the survival of patients with a nutritional risk, a severe nutritional risk, was actually reduced. Okay, this is not really new. We know that the patient who is malnourished or at risk of malnutrition has a shorter survival. So this is not really new. What is really new is in the next slide. Because if you look only at these patients, so the patients with malnutrition or risk of malnutrition who died in a shorter period of time, and you stratify these patients according to the nutritional intervention they received, you will see that the worst outcome is for the patients who receive no nutrition support. And those who receive any kind of nutrition support, like dietary advice, oral nutritional supplement intervention, or major intervention, which means enteral nutrition, they had a better survival. So it really seems, although again, the study was not really looking at these effects, however, it really seems that feeding a cancer patient during active treatment is associated with a better outcome. What about actually omega-3 fatty acids? Well, we know that very well that omega-3 fatty acids may have positive effects, for example, in carcinogenesis. This is just a very recent study, again, showing the importance of supplementing omega-3 fatty acids. But this is another interesting study, epidemiological study coming from the US. And the question was, what happens to patients with diagnosis of colorectal cancer if actually they are increasing the amount of omega-3 in the diet after the diagnosis. So let's say that you have a patient with a diagnosis of colorectal cancer, and then he or she increases the intake of omega-3 fatty acids. You see here that there is a significant reduction in the colorectal cancer death. So it really we don't know why is this happening because unfortunately this is an epidemiological study, so we don't know. But we know that the colorectal cancer specific death is reduced if the patient increases omega-3 fatty acids intake. This is a study coming from Japan. Again, patients with gastrointestinal cancer receiving an oral supplement enriched with omega-3 fatty acids. Let's look at the survival. Again, if you look at the total cohort, again, no apparent effects of supplementing omega-3 fatty acids. But if you look only at the patient with the modified Glasgow prognostic score of 1 or 2, so those patients with increased inflammatory response, you will see that those with the fish oil-enriched nutrition had a better survival. So again, small study, you see here, a small study, but really highlights one important message, that we have to identify the need of the patient, the metabolic need of the patient, provide what the patient need. Because in nutrition and oncology, on one size fits all doesn't really work. We really need to ask our patient which are the needs, look at the metabolism of the patient, then provide what the patient really needs. This is a study we just did, again, with the omega-3 fatty acids, and there is a significant reduction in heart rate in these patients. You would say, who cares about heart rate? No, because you know, it has been demonstrated by a German group a few years ago, you know that high heart frequency is associated with a worse outcome. So the cancer patient with the reduction in the heart rate, they have a longer survival. But we have to face the reality. When we meet a patient with advanced disease, the patient many, many times has problems, nutritional problems, but has other problems. And focusing only on nutrition may not be associated with a better outcome. That's why Ken Fearon, already 10 years ago, was really advocating the use of the multimodal therapy for the patients with advanced disease. He was always making this joke. If you are in the desert and you have a terrible pain in your tooth, but you don't have anything, what you can do? And people was thinking, okay, what can happen? I will try to aspirin. You don't have anything. You are only dressed like you are now, but you have a terrible pain in the tooth. What will you do? The point he was making is that then you put on tight shoes, because then it will be your foot will be hurting you, and you completely forget the tooth, which means really that if you have a patient with many symptoms, just focusing on one doesn't really improve the quality of life of these patients. And more importantly, it has now been demonstrated that this approach is highly effective. So using supportive care, so using treatments to target the so-called patient-reported outcomes, these are extremely effective in improving the survival of the patients, at least the quality of life. This is just a recent study. I just want to go directly to the Cochrane analysis. You see here that at this time, April the 5th, 2018, if you have an advanced cancer patient receiving treatment, if you want these patients to improve their quality of life, you must provide early supportive care. You must, because it has been demonstrated, it's a grade A recommendation. It will be malpractice if you not do it. If the patient sue you because you're not taking care of his pain, you're not taking care of his anorexia, you're not taking care of any other problem except the tumor cells, that will be malpractice because it is grade A recommendation. This is just another study that we did recently, a meta-analysis showing that, for example, for body weight the combination of energy and omega-3 fatty acids is really the key combination to improve body weight of these patients. And this is a very interesting study because now they are developing apps for the tablets and for the smartphones. With 14 symptoms, your patient can be hundreds of kilometers away from you, but when one of these symptoms become not too strong, he just click one of these one of these symptoms, immediately you are informed, you call him and you solve the problem. And you see here that the patients visiting the emergency room is significantly reduced. And more importantly, in this study, also the survival of these patients is improved just by having a direct contact and just by solving a problem as soon as the problem develops. Now, I told you that there is absolutely no doubt about quality of life. We have still some doubt about survival. This is, again, the most recent Cochrane analysis showing that indeed there is a trend over an improvement in survival for those patients receiving early palliative care, which means receiving patient-reported outcome targeted treatment during active treatment, but this is still, not significantly so. But definitely there is absolutely no complete evidence for the quality of life. And interestingly, this is American Society of Clinical Oncology, and they say that every cancer patient who is diagnosed with cancer must be seen by a panel of experts on palliative care within 8 weeks of diagnosis. So we should not wait. Every patient after diagnosis immediately should be seen by someone like you. You may say, okay, you don't have problem now. Let's meet again in 1 month. But every cancer patient should meet within 8 weeks of diagnosis these patients. So in conclusion, I think that we all agree that the clinical journey of a cancer patient is a long journey. And during this period, the nutritional status can be, as I can, challenged by metabolic disturbances because of the tumor, but also because of the treatment the patient is receiving. What is important that we remember is that during this long journey, there are windows of opportunities, and we have to use these windows of opportunities to maximize the recovery, the anabolic potential of our patients. Up to 3 months before death, cancer patients are still able to put on muscle mass. So we really need to use these windows of opportunities. So what to do? First of all, meeting energy and parental requirements. And of course, we can use specific nutrients like omega-3 fatty acids, maybe arginine, to improve actually the immune response of these patients. And more importantly, the monitoring of these patients should be intensive and proactive. We have to ask the patients what are their feelings, what are their symptoms, because otherwise we will never be able to treat them optimally. And I really would like to conclude with a statement by William Osler, who was saying that the good physician treats the disease, but the great physician treats the patient who has the disease. And thank you very much for your attention.